While you're running around seeing patients in the emergency department, the triage nurse comes up to you and says, "There's this patient who seems really paranoid. They're a little off. I don't think they've been taking care of themselves. I'm not sure what to do. They just don't seem right." And you wonder, are they acutely psychotic?
And the next patient to be seen for their bipolar disorder is also complaining of nausea, vomiting, as well as some tremors. And you wonder, are they on lithium and could they be toxic from it?
In this episode of Critical Decisions in Emergency Medicine, we will talk about acute psychosis evaluation and management.
We will also talk about lithium toxicity.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices mostly in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the April 2025 episode of Critical Decisions in Emergency Medicine podcast. And if you don't know what this publication is, what are you waiting for? Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
There are also a lot of other features, such as the critical ECG, Clinical Pediatrics, as well as our listeners know my favorite, the LLSA Literature review.
So for our first lesson, Puzzling It Out, Acute Psychosis Evaluation and Management, thank you to Drs. Anjali James, Vivek Medipalli, and Parag Mehta for writing this article.
Similar to the 2 cases we just mentioned, psychiatric emergencies are common and sometimes quite challenging to manage due to varying resources at different sites, and they're increasing in frequency as well.
Absolutely. In patients with psychiatric emergencies, our number one priority is to determine if the symptoms of acute psychosis are solely due to a psychiatric condition or if there's an underlying medical need. Interestingly, up to 4% of patients who are medically cleared, and I'm using air quotes for that one, and are sent for psychiatric evaluation have some undiagnosed medical emergency that requires that they're transferred back to the hospital.
Let's start with definitions then. What is acute psychosis?
So acute psychosis is a multifactorial condition marked by a detachment from reality. It commonly presents with paranoia, cognitive changes, and impaired self-care. It typically affects young adults but can occur at any age, often complicating the diagnosis in older adults with concurrent medical illness. It can become a medical emergency when the behavior is erratic or dangerous. And when we think of symptoms, they can either be positive, like delusions, hallucinations, disorganized thinking, or negative, like emotional withdrawal, apathy, poor communication.
So what are some possible causes for acute psychosis?
So medical causes, which we usually call organic psychosis, causes a little bit more than half of the presentation. Things like toxic metabolic syndromes, hepatic encephalopathy, renal encephalopathy, infections, including CNS infections, neurologic disorders, autoimmune disorders, neurodegenerative disorders, or trauma. Non-organic causes are things like schizophrenia and mood disorders with psychotic features. Those have 2 peaks, below the age of 35 and above the age of 60.
Got it. So what about an approach to evaluating these patients who are presenting with quite undifferentiated psychosis?
So our initial priority in these patients is to gather a thorough history, and that usually requires collateral information from EMS, caregivers, or medical staff if the patient cannot provide it. Things like symptom duration, potential triggers, substance use, medications, trauma, prior history. And then we need to do a careful physical exam. We need to look for signs of injury, a good head and neck exam, vital signs. We need to look for things like delirium, endocrine disorders, infections. And then when we do a psychiatric assessment, we need to ask about things like the mood, thought content and process, delusions, hallucinations, history of the psychiatric illness or substance use. An important thing to think about here is that delirium is an important differential that's often missed, and there are formal diagnostic tools for that, such as CAM, the confusion assessment method.
That makes sense. Now, how about laboratory studies that we can get?
Well, other than obtaining a finger stick glucose, like a point of care one, there's no standard for medical clearance. Again, air quotes for that one, because that's just such a weird thing. You're not going to clear people of medical things. You just try to make sure that it's not actually affecting their presentation. So ASAP, they do have a clinical policy, and they say that there is no level A recommendation for the required testing in acute psychosis when the vitals are normal and the history is non-contributory. So We might want to do additional testing like a CVC metabolic panel, thyroid study, syphilis testing, toxicologic screening, but those are usually for ones where they don't have a prior history. The onset of symptoms is really off age-wise, like really late, or their vital signs are abnormal. If we think that they have atypical features or neurologic deficits, then that's where neuroimaging may be helpful. Toxicologic screens should not delay the psych evaluation or transfer if the patient's cooperative and alert. Yes, substance use may contribute to the psychotic episodes, but it's often a comorbid condition that does not exclude the need for psychiatric care and stabilization. Another sticking point is an alcohol level. And some people are fixated on a specific level after which you can assess the patient, and that is not a thing. The alcohol level itself does not matter as long as the patient is able to answer appropriately and complete a formal mental status exam.
That makes a lot of sense. What about triage of these patients?
Well, identifying the symptoms of psychosis, whether positive or negative, can happen as early as triage. The triage also typically includes a safety risk assessment focused on suicidality, homicidal ideation, acute hallucinations, and that can help us figure out the risk level of the patient. When we say low risk, we're typically thinking of cooperative patients with depression, anxiety, minimal self-harm. They're accompanied by supportive individuals or have like a strong support structure. Moderate individuals may have suicidal, homicidal thoughts as well, maybe a little agitated, but they're responsive to de-escalation, or they have a little bit of an elopement risk. High-risk patients are the ones that are under an emergency hold, whatever that's called in the area that you work in. They're combative, they're aggressive, they have overt psychosis. And that risk level is important so that we can know how often they need to be monitored and how much additional security we need. A common thing that we do is that we identify psychiatric patients with specific gowns, and there are thoughts that may enhance safety and streamline care.
Definitely. Now, and you mentioned safety, so what particular measures should we take for these patients?
So effective triage is critical so we can prioritize resources and ensure safety. The high-risk patients that we talked about earlier, those obviously require special precautions like environmental safety checks, contraband prevention, minimize access to potential weapons. Staff should remain aware of their own safety and avoid bringing unsecured items into the room, position themselves for a quick exit if needed. It's a whole talk about this one, right? There's a lot of measures that we can do to keep ourselves and our patients safe.
That makes a lot of sense as well. Now, let's say if one of these patients do become more violent, how can we manage that?
So, violent behavior is quite common. It occurs in 1 out of every 5 patients with acute psychosis, often presenting with agitation that escalates to aggression. The priority is safety while helping patients to regain control without resorting to restraints, which carry significant risks, are actually strongly recommended against by Project Beta, which is best practices in evaluation and treatment of agitation. Our first step is verbal de-escalation, usually around 5 to 10 minutes. After that, if it's not working, then it's not working. And it should be our first line approach and should be patient-centered. If it's unsuccessful or the need for that becomes too time-consuming, as in numerous attempts at de-escalation every few minutes or so, then medications such as antipsychotics or benzodiazepines may be used. A multimodal approach to agitation rather than relying on one single intervention is usually preferred.
I don't know about you, but I definitely have some preferences. So that gets to our age-old question. Do you usually reach for antipsychotic or benzodiazepine?
Well, if you know me well enough, Wendy, and I know that you do, you know that I also personally have a preference. However, other than our personal preferences, there's no clear consensus on which one is quote unquote better. The options that we have are our first generation antipsychotics like our haloperidol and droperidol, and they've long been used for acute agitation. There are a couple of risks are like your QTC prolongation and extrapyramidal symptoms. Our second generation or atypical antipsychotics, you have olanzapine, ziprasidone, aripiprazole. Those don't carry as much of the extrapyramidal symptom concerns. Benzos are lorazepam, diazepam, midazolam. Those are valuable, especially in cases of stimulant use, alcohol withdrawal, or unclear agitation. What some people think is if we're thinking of stimulant intoxication or withdrawal, then benzos is the answer. If we're thinking of a CNS depressant intoxication, delirium, or known psychiatric illness, then antipsychotics is the way to go. And in some cases, a combination may be appropriate. However, in the article does not get into that in details. There are studies that show that combination medications may have more side effects, but that's also a conversation for another day.
Got it. Now, this is the toughest part. How do we dispo these patients, especially when we know psychiatric resources are so limited?
Well, I think the first question is, are they here for acute psychosis that's non organic, or is there a medical cause that's identified, like an infection? If it's purely acute psychosis, there are no acute medical needs, then they may require transfer to a psychiatric facility. But if a medical cause is identified, then they need to be admitted to the hospital for medical management. And that's why it's really important that we evaluate for medical causes before we just say, oh, it's a psychiatric disorder. It's important to get these patients to care because a delay in addressing first episode of psychosis can lead to worse outcomes. Of course, when a patient poses a risk to themselves or others, then we may need to enact an emergency hold, which again carries different names in different states. The authority to do that can vary by state, but includes police, physicians, nurses. And in these situations, if we have access to mental health professionals, then we may work with them to determine the appropriate care. But at the end of the day, the final decision rests with us because we are the people who are taking care of these patients and seeing them in real time in their acutely psychotic episode and understand what care they need.
Now, can you touch on a little bit about medical legal considerations, especially with EMTALA?
Well, EMTALA can be quite a concern when we're thinking about how are we supposed to evaluate psychotic patients? Well, what happens if something bad happens after they're discharged? And reality is that if we have clear documentation that shows a proper medical screening and stabilization, then that decreases our risk for poor outcomes. Now, if it's a patient with a first time episode of psychosis, then the legal precedent highlights the importance of involving a mental health specialist in managing that. Because there has been a case where a physician discharged a psychotic patient without psych consult, had a tragic outcome, and in that case, the legal precedent was highlighted. And that's why a safe disposition is important, even if the patient wishes to leave. At the end of the day, it is up to us to determine if they need an emergency hold.
That makes sense as well. Now, what about stigma associated with psychiatric illnesses and psychosis?
We need to recognize that patients with acute psychosis are often stigmatized in emergency departments, and they're viewed as disruptive rather than critically ill, which can lead to premature dispositions and compromised care. There's structural biases, individual biases. We tend to prioritize medical patients over psychiatric patients. We don't really have good triage tools that pick up on the true acuity of these patients. And the ED environment does not really help. It's highly stimulating, there's not much privacy, and that is just the perfect storm. That's why we, unfortunately, as physicians, may end up avoiding psychiatric patients, and that avoidance can lead to infrequent monitoring, delayed care, and that can create a cycle where patients can perceive psychiatric treatment as punitive and reach out to us even less. And then just combine that with longer boarding times, it's just really difficult for these patients. And that's why involving leadership to promote a patient-centered approach, targeted education for staff, and collaborate with psychiatric services to ensure a safe, effective care for this vulnerable population is our first step to move forward from this unfortunate dynamic that we're in.
Well, thank you, Danya, for taking us through this very important lesson. I think it's a great reminder that when patients are presenting with psychosis, and maybe that includes symptoms of paranoia, cognitive changes, these are often very challenging symptoms to evaluate, especially as our role as emergency physicians to assess and differentiate whether this may be from an organic versus a non-organic cause. Our job is to definitely get adequate history as much as possible from family, EMS, etc. Do a thorough exam, including for signs of trauma or substance use or other clues of medical illnesses. And then, of course, assess their mood, their thought content, assess whether they have any prior history of psychiatric illness to help us, again, determine what is the likely cause of their presenting symptoms. And oftentimes we are asked to provide this medical clearance, and you reminded us that really there's no recommendation for any required testing. It really should be driven by the patient's history and presentation, with, of course, a more extensive testing probably needed when patients are presenting without a prior history of psychiatric illness and are presenting with a first-time new onset psychosis. Our triage is also very important as it helps us assess their risk level, especially in terms of safety for them as well as for the ED and staff. And that also includes, of course, removing potentially harmful objects from the environment, as well as our own safety measures when we are assessing the patient in the room. Now, in terms of specifically managing potential violence, obviously de-escalation is always ideal to begin with, but sometimes we may need to reach for medications, whether antipsychotics or benzodiazepines. As you also mentioned, there's no particular algorithm for this, but oftentimes we think about the constellation of symptoms they're presenting with to help us decide whether one or both may be necessary to treat them. We all recognize that ultimately disposition of these patients is challenging because of limited resources, but once we've determined whether they have more of an ongoing medical need versus a purely psychiatric need, hopefully that helps streamline things somewhat. But like you also mentioned, if once again a patient is presenting with their first time psychosis, we really want to make sure we involve our mental health specialists in their evaluation to assess their safety in the ultimate disposition plan. And finally, great reminders in terms of the potential stigma associated with these patients' presentations, not only from generally the not ideal setting in the ED that can further exacerbate their symptoms, but also our own potential biases in this patient population.
Well, thank you for summarizing such a thorough article. For our Clinical Pediatrics this month, we have a case of a teenage girl presenting with fever, abdominal pain, and clear vaginal discharge. Her last menstrual period was 3 weeks ago, and she reports no sexual activity and no concern for sexual abuse. On examination, she has moderate bilateral lower quadrant tenderness, and a GYN exam is deferred given the fact that she's not sexually active. Her workup finds elevated white count, ESR, CRP, she has pyuria, and her HCG is negative. The ultrasound shows inflammatory changes in the uterus and the surrounding ovaries, suggestive of PID.
Now, we often think about PID in sexually active women caused by chlamydia and gonorrhea, but really studies show that only about 25 to 50% of cases are attributed to these organisms, whereas other organisms can be related to the vaginal flora, like Gardnerella, even Haemophilus and Strep agalactia, and some are even caused by respiratory or enteric organisms like E. coli that have colonized the lower genital tract. So treatment should be broad, covering gonorrhea, chlamydia, as well as anaerobes like Gardnerella. In this feature, there's a great table that gives some regimens that you can consider. For patients with mild to moderate PID, parenteral versus oral antibiotic regimens all have similar efficacy. But if the patient is quite ill, or if they're pregnant, have a prior history of PID, if you're suspecting a surgical emergency, such as even with a tubal ovarian abscess, then these patients would require IV antibiotics with inpatient care.
Great reminders and a pretty scary case of something that we don't tend to think about as often. Our critical image this month is a patient who's coming in with recurrent chest pain. He's 59 years old. He's got the chest pain, shortness of breath, and dizziness. Was here a week ago. Normal ECG, normal troponin, stress test, negative. Eval to date, also unremarkable. Heart score is 5. So the emergency physician here obtains a coronary CTA, which shows a 99 percentile calcium score, and diffuse 3-vessel CAD with multiple areas of high-grade stenosis, including hemodynamically significant stenosis in the distal LAD.
This was a really good case, as I'm not as familiar with coronary CTAs as I have not ordered them from the ED before. But it's a great tool to have, as we'll talk a little bit about this. It is a little different from coronary artery calcium scoring, but you can use the pre-contrast images on this coronary CTA to do the same, to quantify the coronary artery calcium. And the benefit also of this test is that you can perform it at rest for evaluation of your coronaries, or combine it with a pharmacological stress agent to really evaluate, of course, perfusion or fractional flow reserve. And so the Society of Cardiovascular Computed Tomography consensus actually states that a coronary CTA is actually an appropriate first-line test for patients without known coronary artery disease and angioequivalent, as well as a follow-up test for those who have inconclusive functional testing. But it should still not be used for low-risk patients per ACEP clinical policy.
Great review, something that's been around for a while, but we don't all have access to and therefore not as familiar with. For our LLSA Literature review, we're reviewing an article by Hausman et al. That was published in AGEM in 2023, entitled High-Dose Nitroglycerin Infusion Description of Safety and Efficacy in Sympathetic Crashing Acute Pulmonary Edema, or the High-Dose SCAPE study.
Yeah, that's definitely a mouthful. Sympathetic crashing acute pulmonary edema, or SCAPE.
Just say SCAPE.
Yeah, SCAPE. I like it. Essentially, we've all seen these patients. They're presenting with acute elevated blood pressure, and then they develop essentially heart failure symptoms with pulmonary edema, often presenting with respiratory distress. And we generally treat these patients with non-invasive positive pressure ventilation and nitroglycerin. So this particular retrospective study looked at high-dose nitroglycerin infusion with or without some of these adjunctive therapies. About half of the patients did receive a sublingual or IV push dose of nitroglycerin before starting the infusion, and they used an infusion that started at 100 mics per minute and titrated up to 200 mics per minute. Ultimately, this group had a large proportion that did get non-invasive ventilation support, almost 3/4 of them. Half of them got a loop diuretic, and about a third of them received an ACE or an ARB in addition for their blood pressure management. And the overall effects on blood pressure reduction was similar. Now, the group that did receive much higher doses of the nitroglycerin greater than 200 mics per minute tended to be intubated, but that was really related to, of course, how sick they likely were on presentation. I think the takeaway from this study is that high-dose nitroglycerin is safe and effective. And so we should consider and not be, I guess, as scared of titrating doses if we need to manage these patient symptoms.
Definitely something to consider in our sicker patients in hopes to try to avoid intubating them. So staying with somewhat of a cardiac theme, our critical ECG this month is junctional tachycardia. It's a case of an 80-year-old female who's coming in with dizziness, chest pain, and tachycardia with an otherwise negative workup. Her ECG shows junctional tachycardia or junctional ectopic tachycardia, they're the same thing, which is a type of non-paroxysmal SVT. And it comes from the AV junction because of enhanced automaticity from an ectopic focus in there. There's lots of causes for it, like chest trauma, sick sinus, myocarditis, medications, ischemia, and so on. And the article goes into lots of details of how to differentiate between junctional tachycardia, AV reentrant tachycardia, AV nodal reentrant tachycardia, and so on, because it can be quite difficult to figure that out. What really matters is that differentiating it from the other types allows us to understand that our typical treatment may not work because we don't have as much data on this condition given its rarity. Patients here will present with a narrow QRS complex, and the presence of P waves would be variable. If they are present, they're going to be at a slower rate than the QRS complex, and it's more or less regular and hanging out around that 130. Definitely worth taking a look at this article to take a look at that EKG and that comparison table. And switching gears to ortho, our critical cases in Orthopedics and Trauma this month is knee pain.
Yeah, it's a case of a 67-year-old female after a motor vehicle collision who unfortunately got her knee impaled by her key. I didn't think our car keys would be extra dangerous in that manner.
Oh, definitely scary.
Yeah. So when you evaluate her, you find that, of course, her key is sticking into her anterior knee, and she can't extend or flex the knee without significant pain. Thankfully, though, she does have intact pulses and her compartments are soft.
Traumatic arthrotomy, which is a fancy word for keys in knee, most commonly affects, well, the knee. The disruption of the joint capsule exposes the articular surface to contamination and can lead to septic arthritis, which is quite dangerous. Traditionally, we can use a saline load test to assess the integrity of the joint capsule, but it can be quite painful for the patient to tolerate. CT is non-invasive, and I didn't know that, has nearly 100% sensitivity in the diagnosis by detecting gas in the capsule.
So in this case, you don't actually want to remove the key or the foreign body in a non-sterile manner, since we can then open up, of course, the joint to air and increase the risk of infection. You want to take the patient to the OR for removal, and then the orthopedics surgeon can perform an inspection of the joint capsule and wash it out if need be. Now, don't forget that we can provide antibiotic prophylaxis, though.
And moving on to our critical procedure this month, it's male urethral catheterization. And you're like, wait, this is usually something that our nurses are fantastic at doing. But reality is that we sometimes are asked to do it if our nurses can't get the results that we need. We can either use a Robinson catheter to straight cath, a Foley catheter and leave it in place, or a Khoujah to help pass the prostate during insertion. What can help is having an assistant to decrease the rate of infection and apply pressure to the perineal area to help direct the catheter.
Yeah, interesting for sure. Now, in terms of the actual insertion, obviously we do want to keep an aseptic technique, prepare and drape the area, retract the foreskin in uncircumcised patients, and then hold the penis at 90-degree angle from the body. Clean the glands and then instill some sort of lubricant or anesthetic to be kind to your patient. And insert the catheter until you're close to hubbing the catheter, and then inflating the balloon.
Sounds quite straightforward, but sometimes it still does not work. Alternatives are to do a suprapubic aspiration or catheterization, which we had discussed in a prior issue, specifically in February, or call urology for assistance. Our second lesson of this issue is little room for error, treating lithium toxicity. Thank you to Doctors Catherine Clark, Sharon Pang, and Noral Jalbout for writing this article. Lithium is commonly used for management of bipolar disorder, but it has such a narrow therapeutic window. And that's why I think it's really important for us to understand and recognize the toxicity, whether acute or chronic.
Very true. Now, the article shared some statistics that's quite scary, which is that most patients on lithium will experience at least one episode of toxicity in their lifetime. Now, historically, lithium toxicity is associated with mortality up to 25%, but thankfully, more recently, it's much lower, down to 1%. We do need to talk a little bit on pharmacokinetics. So as a refresher, it is rapidly absorbed from the GI tract. It does have a long half-life of up to 24 hours. So it really reaches steady state in about 4 to 7 days. It is 95% renally excreted, so that's very important in sometimes our management of these patients. Because if it's high water solubility, it is dialyzable, especially when we need to utilize it for toxicity. Now, it in itself can cause nephrotoxicity at high concentrations. The big things we have to worry about are patients on some medications that can, of course, alter and increase the concentration of lithium and then precipitate toxicity. And these medications would be NSAIDs, renin-angiotensin inhibitors, thiazide diuretics, spironolactone, and even calcium channel blockers.
Quite common medications. So, what are the signs of symptoms of lithium toxicity that we should be aware of?
In general, toxicity can affect the GI, cardiovascular, neuro, and renal systems. So in terms of GI symptoms, patients can present with nausea, vomiting, and abdominal pain, especially with acute toxicity. Now, lithium itself may cause some nausea as a side effect, but vomiting is quite rare. So if patients are coming in with that, you should be worried about toxicity. In terms of cardiovascular effects, we do look for things like flattened or inverted T waves, prolonged QTC, heart blocks, and ventricular tachyarrhythmias. And the higher lithium concentrations can also correlate with the QTC prolongation. In terms of neuro symptoms, we're generally thinking about drowsiness, confusion, tremors, ataxia, or even seizures and encephalopathy. Now, the tremors associated with toxicity are generally coarser and more disabling than patients who are simply therapeutic. And there's a particular syndrome called syndrome of irreversible lithium effectuated neurotoxicity, interestingly with the acronym SILENT. And that includes cerebellar dysfunction, extrapyramidal symptoms, brainstem dysfunction, dementia, and vision changes. So quite scary symptoms for sure. And then renal symptoms. We all know lithium can be associated with nephrogenic diabetes insipidus. So these patients may present with polydipsia, polyuria, or nocturia. And just being on chronic lithium use, it can also just simply have an antidiuretic hormone effect. So definitely there's a risk of renal injury and failure.
Quite variable presentations. What are some other conditions that we should consider in our differential?
Certainly for some of those neuromuscular excitability symptoms, we will want to consider neuroleptic malignant syndrome, serotonin syndrome, or even alcohol withdrawal or benzo withdrawal. Now, one thing to pay attention to is that lithium itself, though, can precipitate serotonin syndrome. So if patients are on both medications, that would be something to pay attention to. We also want to consider potentially other medications that can lower the seizure threshold or cause seizures, like TCAs, bupropion, cefepime, meropenem. And then don't forget about other medical conditions like hypoglycemia or even thyroid dysfunctions like myxedema, coma, or thyrotoxicosis.
Got it. So back to lithium toxicity, how do we grade the severity?
Well, first, we have to consider a bit on whether this could be an acute toxicity, acute on chronic toxicity, or chronic toxicity. The reason being is that the more acute toxicities generally present initially with GI symptoms, then the neurological symptoms later, whereas chronic toxicity generally are presenting with neurological symptoms. And then in terms of the severity of their toxicity, certainly we use the lithium level as a general basis, although some studies suggest that it really doesn't correlate well with morbidity and mortality. But the teaching is that with mild toxicity and lithium levels generally between 1.5 to 2, you may see symptoms of nausea, vomiting, tremors, agitation, and ataxia. Whereas with moderate toxicity, with lithium levels between 2.5 to 3.5, you may see more severe symptoms like stupor, hypertonia, or hypotension. And then with severe toxicity, where your level may be greater than 3.5, you're really dealing with some patients who may be comatose, having seizures, and myoclonus.
Got it. So, what tests should we obtain in our evaluation? I know lithium level, probably, but what else?
Right. Really, we're using the lithium level to confirm that they've had it in their system, so confirm the exposure. But remember that depending on when we're seeing the patient, maybe it doesn't represent the peak level. And like we already mentioned, it doesn't really correlate with the clinical toxicity. We do want to trend it to get a sense of what is the absorption and distribution happening in the patient. And then other tests that could be helpful are your standard tox workup like CBC, BMP, tox screen, thyroid function, ECG, UA, because you're really looking for potential co-ingestions and, of course, other confounding medical conditions as well.
Makes sense. So, how do we treat lithium toxicity?
Well, activated charcoal is not effective because it does not get absorbed. If you're dealing with an acute ingestion of extended release formulations of lithium, you can consider whole bowel irrigation. But generally, in terms of supportive care, we're talking about fluid resuscitation because most of these patients can present hypovolemic and also with a sodium deficit. So you're giving boluses of normal saline initially. We don't generally recommend diuretics early on, but ultimately, because of the risk of renal injury, we do want to balance, of course, adequate urine output while maintaining an even fluid balance. Now, I mentioned dialysis. It is quite effective in removing the medication. And so, in very severe cases of toxicity, whether it's high initial lithium levels, or if they can't tolerate fluid resuscitation, or if they're presenting with really severe symptoms like seizures, dysrhythmias, then you may need to consult nephrology and also toxicology to talk about hemodialysis. The one other caveat is that after dialysis, though, you still need to follow levels because there could be further redistribution of the medications from tissues. So the patient may need more than one session.
Got it. So, how about the disposition of these patients? Do we need to admit all of them?
I think most of these patients we do need to, especially if they have ingested extended release formulations. Those are must admit and you have to monitor their levels and their symptoms. Now, if they're coming in and their initial level is greater than 1.5, then you would also want to admit them. If they are asymptomatic and their lithium level is downtrending and they have normal kidney function after your period of observation, then it is reasonable to discharge them.
Makes sense. Thank you, Wendy, for reviewing this article. Definitely learned a lot about lithium toxicity. Definitely didn't realize that most patients on lithium will have at least one episode of toxicity in their lifetime. It has a rapid GI absorption and then stays in steady states for like 4 to 7 days. And it's really excreted, which is why it's dialyzable. And that some medications can actually precipitate toxicity, such as NSAIDs and spironolactone and thiazides, which are quite common medications. Patients can come in with vague GI symptoms like nausea, vomiting, and belly pain, some cardiovascular symptoms such as EKG changes, but those are not really that common. And neurologic symptoms, and those are usually on the later side, especially the tremors, drowsiness, poor concentration. And some of the neurosymptoms can be quite irreversible. We can also have renal symptoms such as nephrogenic diabetes insipidus, and chronic use could cause antidiuretic hormone resistance and eventually renal failure. There's lots of differentials. They can be either related to drug use, as in medication toxicity use. We can have seizures from other medications such as tricyclics or from decreased seizure thresholds. And then things, of course, like thyroid dysfunction, hypoglycemia, and so on for the drowsiness and neurosymptoms. It's important to remember that they can be acute on chronic, or chronic. And that correlates usually to the lithium levels that are there. Something to remember is that chronic toxicity is usually more of a neuro thing, and GI symptoms is more of an acute or acute on chronic thing. Obviously, the higher the level, the sicker the patients are. When we're getting the levels, which obviously we're going to get to confirm the patient's on lithium, it's important to know that it may not represent the peak level and it may not correlate with a clinical toxicity. And that's why we need to repeat it every 4 to 6 hours to trend the absorption and the distribution. And then, of course, we need to look for other causes for patient's presentation. So get a blood count, a metabolic panel, a tox screen, and all of that. Activated charcoal is not an option for an acute ingestion. For these patients, we mostly focus on aggressive fluid resuscitation and correct electrolyte abnormalities. And then, of course, in patients who are super sick, dialysis is going to be necessary and, of course, quite effective. Most of these patients are going to end up being admitted, even sometimes to the ICU if they have severe symptoms. However, if they are asymptomatic and we have downtrending lithium and normal renal function, we may be able to discharge these patients home. And for our drug box this month, acetaminophen? Really? But hold on, IV.
Yeah, that's right. We wish we can give IV acetaminophen to everyone, right? People say it's more effective than parenteral.
Placebo effect, right?
Right, exactly. But it is a good reminder that acetaminophen, when we use it with an opioid, such as in some studies looking at acetaminophen with morphine after major surgery, it really reduced the opioid needs. And the use of NSAIDs with acetaminophen has also been more effective than NSAID alone. Specifically, though, we do consider the IV formulation when we're dealing with patients who can't get acetaminophen via the oral or rectal routes. Now, also a good reminder that we shouldn't exceed 4 grams per day in adults or 75 milligrams per kilogram per day in children or smaller adults, such as those less than 50 kilos. Other considerations are patients with hepatic insufficiency, chronic alcohol use, malnutrition, and dehydration to potentially reduce their dose. Now, specifically, though, with the IV acetaminophen, sometimes people have observed some transient blood pressure reductions, especially in critically ill patients. So just be prepared for that.
Got it. And last but not least, our tox box this month is isoniazid toxicity. So isoniazid is structurally similar to niacin, which is B3, and pyridoxine, which is B6. The toxicity is due to induction of functional pyridoxine deficiency. Symptoms include seizures, especially with ingestions of 20 milligrams per kilo or more, coma, lactic acidosis, tachycardia, hypotension, hyperthermia, rhabdo, and AKI. In chronic toxicity, we can see things like hepatotoxicity, peripheral neuropathy, optic neuritis. If there's a recent ingestion, then we can give activated charcoal. And the antidote is IV pyridoxine with a 1-to-1 ratio of the ingested dose, up to 5 grams. Benzos can have reduced efficacy in these patients if they're seizing. And we need to consider hemodialysis if the patient has refractory seizures and pyridoxine is not available. Well, thank you, Wendy, for taking the time to go through this issue with me. I learned a lot. Our dear listeners, I hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope that you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Follow us on social media. My handle on Instagram is at Dr. Danya Khoujah, and that's the same for Threads.
And mine is at Dr. Wendy Chang.
And on Blue Sky, it's Dr. Danya. And until next month,
bye-bye.